to our webinar presentation this afternoon. I'm Bob Williamson. I'm a medical science liaison with Baxter, and I have the privilege of being with you today to help facilitate today's session. Today, you're in for a treat. This is part 3 of our Helping Reduce Injuries and Improve Safety Outcomes in an Acute Care Environment. Just a brief description of our presentation today that's going to be led by Kellie Clapper is in the 3rd and final installment. Kellie will provide a clinician's perspective on the physical burdens of patient mobilization, patient transfers, and repositioning, and how they can all be successfully managed within a large acute care environment. Ms. Clapper is going to share some practical solutions on advancing caregiver and patient safety within her organization as they've adopted an interdisciplinary approach titled We Move Together. So please join us for this wonderful presentation. A little bit about Kellie, and I've had the privilege of working with her the last year and a half or so. Kellie obtained her Bachelor of Science in Occupational Therapy from Creighton University. She started her career in post-acute and then transitioned into an acute care environment where she manages a very large inpatient rehab service at Nebraska Medicine. Her career is really focused on building and sustaining successful programs. And the evidence I've seen in working with her is she is a great team player and pulls the interdisciplinary model in place, which you're going to see here. Before we get started, I just have a few reminders for you. Today's session is going to be muted. We do that simply because of so many people that are on this particular call. It would just it'd be really challenged to open it up. Second, all the content that you see here is going to be presented is been developed and curated by Kellie. Any questions specific to equipment or anything relative to Baxter, those questions should come, and they can come into the chat, and they'll be managed through medinfo@baxter.com. Additionally, this webinar is going to be recorded and is available for purposes following the webinar. Usually it takes us several days to get that accomplished, and a link for that recording will be there for you. And last, and certainly not least, before we get started with today's presentation, on the screen you see here, it's very important for you to provide us an evaluation. Yes, it's important to hear about Kellie's presentation, but more importantly for us as well, we want to know what types of presentations add value and are things that would be attractive for you to visit in the future as we host these webinars to provide evidence generation and science for you. So without further ado, I would like to turn the mic over and the presentation over to my friend and colleague, Kellie Clapper. Kellie?
Thank you for the introduction, Bob. I also want to give a shout out to Neil and Jake for their presentations and work. It's really helped guide and direct some of the work we're doing at Nebraska Medicine. I'm really excited to be here today to present the efforts we've made at Nebraska Medicine to foster a culture of safety for our patients and our employees around patient mobility and falls. Given the scope of what I hope to cover today and the 50-minute time limit that we have, I won't be able to explore every detail in depth. However, my goal is to offer a foundational framework and share some insights that can hopefully help revitalize and strengthen your safe patient handling mobility program at your facility. So get ready. I have a lot of content and I want to get through that for you. So Nebraska Medicine is in Omaha, Nebraska. We're an academic health system. We're affiliated with the University of Nebraska Medical Center. We have 2 hospital locations and a total of 809 acute care beds. We're a level 1 trauma center and a comprehensive stroke and transplant center. We are the largest hospital in our region, and we receive patients from many different states, and we keep very busy and averaged almost 31,000 discharges in 2003. So the past several years, our healthcare system has really been challenged by the pandemic and nursing and care tech shortages. We are experiencing higher acuity patients and patients of increasing size And we're asking our teams to mobilize patients earlier and more often. The combination of these factors has really challenged our traditional approaches to patient handling, specifically manual lifting and training in body mechanics, and they are no longer effective in and of themselves. So given these escalating challenges and the increasing strain on our traditional patient handling methods, it was clear that our approach needed to evolve. So the impact of these changes is really illustrated in the rise in fall-related injuries and safety events that we've seen not only at Nebraska Medicine, but I would say nationally. Nebraska Medicine experienced 15 sentinel and serious safety events between July 1st of 2022 and January of 2023. That was a 50% increase in the number of events compared to the same time frame during the previous fiscal year. This troubling trend, and coupled with the growing number of work injuries related to patient handling, underscores just the urgent need for a more comprehensive strategy. So at an organizational level, we decided to expand our focus from solely fall prevention to encompass overall safety and mobility. This shift really aligns with a national trend among healthcare organizations to integrate early mobility, safe patient handling, and employee safety with fall prevention initiatives, recognizing their interconnectedness. So as a part of this transition, our inpatient fall committee was disbanded, and we restructured into a new mobility and safety committee. So I'm going to talk just a little bit about this committee. It's dedicated to developing and leading a comprehensive safety and mobility program to promote early mobility, ensure safe patient handling, and minimize harm to both patients and our staff. We concentrate on several key areas: falls, both assisted and unassisted, falls resulting in injury, and the use of safe patient handling equipment, mobility assistive devices, and then employee injuries related to repositioning, lifting, and transfers. The committee is accountabilities really help drive our mission to enhance patient and staff safety. Again, we're focused on reducing the number of falls that result in injury. The committee is responsible for regularly reviewing and updating our policies and procedures related to early mobility, safe patient handling, fall prevention, and employee injury. This committee will oversee the development and dissemination of our education and training programs to really ensure that all our team members are well informed and equipped to implement these practices effectively. This committee will be involved in evaluating and recommending products and equipment that support fall prevention and safe patient handling and mobility. And then that includes assessing the latest technologies and tools to enhance our safety measures. We'll monitor data and trends to determine our ongoing metrics, and we utilize the ND and QI benchmarks to really gauge our standing on a national level and identify areas for improvement. So our falls committee previously was staffed by mostly acute care nurses. So this revitalized mobility and safety committee now has representation from a variety of disciplines, including executive sponsors. We have nurses, care techs, mobility aides, OTs, PTs, respiratory therapists, physicians, our safety manager, employee health, even an EMR analyst, and our clinical nurse educators. Because falls is not just a nursing concern, and mobility is not just a rehab, it is rehab's concern. Really creating a team approach to this was essential. Literature shows that the importance of leveraging the expertise of various disciplines for a more comprehensive approach to reduce the risk of immobility and falls. Multiple interventions for fall prevention and safe patient handling involve collaboration of the whole healthcare team. So our Mobility and Safety Committee is made up of our mobility and safety champions, and they really play a vital role in our program. Ideally, these are employees that are motivated, enthusiastic, and strong leaders with a focus on quality measures. They carry out important tasks such as conducting our fall prevention audits, training new staff, and celebrating those who excel in promoting patients and safety. They also educate the team about mobility and safety updates, attend our monthly meetings, and share useful tips and best practices. They really set the stage for creating a strong culture of safety and help us focus on continuous improvement. So we established our Mobility and Safety Committee in the summer of 2023. We've had a pretty aggressive timeline due to the increasing number of falls and employee injuries we were experiencing. And in my opinion, I think we've had some major accomplishments just since January of this year. So as I said earlier, I won't have time to touch on everything that we've done. Today, I'm really going to focus on the foundational work that we had to complete at an organizational level to develop a safe patient handling and mobility program and to create a culture of safety for our patients in mobility. So I'll be highlighting the implementation of a mobility assessment tool, changing our fall risk tool, onboarding and education of those changes, and then the new process we implemented to collect, audit, and trend employee injuries related to patient mobility. I'll also highlight our We Move Together campaign. So the first component of our Mobility and Safety Committee is the falls aspect, and that is led by a certified nurse specialist. And so the first few months, our operational improvement informatics and clinical nurse specialists scoped our current state workflows related to falls, collected data related to falls. They reviewed literature to determine best practice and identified gaps in our current practices. Based on this work, we established our guiding principles to streamline and make effective processes that would lead to a reduction in falls and fall-related injuries. One of our guiding principles was really to implement a user-friendly and standardized fall risk assessment tool. And so after months of exploring and comparing various tools, we looked at the Johns Hopkins, Hester Davis, Stratify, SCHMID, and the modified SCHMID. We decided to move away from the modified SCHMID and move to the Hester Davis fall risk scale. So if you're not familiar with this, has 9 areas, assessment areas within the tool. Each assessment area is assigned a score based on the level of risk it represents, and then the total score determines the overall fall risk level of the patient. The higher the score, the higher the risk of the patient falling. So the Hester Davis tool also allowed us to stratify the patient's risk of injury into low, moderate, and high, and then customize interventions, fall interventions at each of these category levels. Our previous tool did not have the risk injury stratification. As a part of this work, we also, I think, is pretty innovative in a sense that we worked with our EMR analysts to build the new tool and then utilize predictive analytics to assist the nurses in documenting the patient's fall risk. Also out of this work, we were able to develop a new post-fall huddle and documentation in our electronic medical record. Second component of our Mobility and Safety Committee is mobility and safe patient handling equipment, and I spearhead this section of our committee. And we established similar guidelines, guiding principles for implementing a mobility assessment tool to promote early and progressive mobility. Our goal to addressing safe patient handling and mobility was really to reduce physical effort of our staff, optimize patient comfort while promoting early and progressive mobility, but at the same time, maintain efficient workflows for our staff. We also wanted to make sure that the early mobility interventions we implement were based on evidence-based practice. because the evidence does support that a combined approach to using safe patient handling, mobility assistive devices, and proper training can keep our caregivers and our patients safe. So we chose the bedside mobility assessment tool as the tool we incorporated at our hospital. And we really wanted to incorporate a mobility assessment tool to enhance our patient and employees' safety. The BMAT promotes safe mobility by encouraging early and frequent assessment and ensuring that we address mobility needs proactively. It establishes a common language for communicating a patient's mobility status amongst our healthcare team. And by meeting the patients where they're at with their mobility levels and utilizing safe patient handling equipment when necessary, we can tailor our approach to each patient's needs. This is our fall risk communication and BMAT sign that is placed in each of our patients' rooms to support consistent communication and inform mobility practices for all our healthcare team. We added the BMAT level to integrate the mobility assessment into our broader fall prevention strategies and help staff start making the connection between utilizing safe patient handling equipment as fall intervention and hopefully to minimize the need for assisted falls and to maintain employee safety. The final component of our mobility and safety committee is, and new, is the employee safety, and that is coordinated by our employee safety coordinator. As I mentioned in the beginning of the talk, we were experiencing an increase in worker injuries related to patient handling. With the growing rate of obesity in America, the higher acuity of our patients, and nursing shortages, the need for safe patient handling equipment and programs is more important than ever. Incorporating employee safety into this committee really made sense. We started a new process doing chart audits of employees who sustain injury during mobility, which focuses on transfer, lifting, and repositioning. So when employee health receives an employee incident, that is forwarded to myself and our certified nurse specialist, and we'll do a chart review to determine if the correct safe patient handling equipment was used or if there's an opportunity for education and training for the employee or the nursing unit. So in this particular example, this occurred on one of our ICUs, and it's actually the only ICU we have of our 5 ICUs that has ceiling lifts. So the employee reported they were boosting and turning the patient with the assistance of a patient care tech, and they were using a lift sheet. So I, excuse me, I go in and do a deep dive to determine what the patient's BMAT level was at the time of injury. I look at the safe patient handling equipment or the mobility assistive devices that they may have used and charted during that patient interaction. I also look at what PT has documented for the mobility score of the 6 clicks. And then I will look at what the OT and PT safe mobility recommendation was documented for our nursing. And then ask, could this injury have been avoided? In this example, the patient was post-surgical with sternal precautions and was documented as a BMAT 1. When I compared to the 6-click score by PT, those seemed to have aligned, and that was the appropriate mobility level for this patient at that time. The nurse and care tech used the turn and position system, so our tap position system to boost the patient. However, we have ceiling lifts in this particular ICU, so best practice really would have been utilizing the ceiling lift and a lift sheet to boost the patient and turn the patient in bed. So then I take that information and we share that with the unit manager with the recommendation for BMAT 1 patients to utilize the ceiling lift and lift sheets for boosting, turning, and repositioning. Here's an example of the employee incident data that we're collecting and trending. This data is reported out at our Mobility and Safety Committee and also shared with our leadership on a quarterly basis. And so throughout my presentation, you're going to see just the BMAT go live and the Hester Davis go live, because I want you to really just kind of zone in on the data from before and after that point, because we are starting to see improvement in our metrics that we are collecting. All right, so part of this talk today was to touch on education, onboarding, and training. So part of the restructure of the Falls Committee to the Mobility and Safety Committee included education for the rollout of our new fall risk tool, the Hester Davis, and of the bedside mobility assessment tool. So as a therapist, many of the safe patient handling and mobility techniques we use are very intuitive, but I've learned over the years that's not always the case for our nurses and our care techs, or even all our therapists when it comes to mobilizing more complex patients. So making sure you incorporate basic principles of safe patient handling and mobility education into your onboarding process is really critical to ensuring a successful safe patient handling program. It also helps establish the expectation for how to keep the patient and the employees safe. So I think the single most important point to really point out when you're developing your education is to tailor the education to the employee role. And different roles within the healthcare team have specific responsibilities, and they face unique challenges related to patient mobility and fall prevention. So customizing the education ensures that each team member develops the skills directly applicable to their daily task, and enhances their effectiveness and their confidence in caring for our patients. Some of the education that we do for our physical and occupational therapists and the use of our safe patient handling equipment looks different than what our education is for our care techs or even our nurses. I'm not going to go through the next two slides in very in-depth. I just wanted to highlight the module objectives for the house-wide rollout of the Hester Davis and for the mobility and safety, or the mobility and safe patient handling education module, which was part of the rollout of the bedside mobility assessment tool education. So within the mobility and safe patient handling module, we took this opportunity to highlight the staff that are trained in safe patient handling and creating a foundation for the We Move Together campaign that I'll talk about here pretty soon. These are also the same healthcare team members that make up our Mobility and Safety Committee. Since this was house-wide education, we also took the opportunity to review safe patient handling equipment that we have at Nebraska Medicine. And we also threw in a teaser for a piece of the Sarah Plus, which is a sit, stand, and walk device that was coming soon to our ICUs. Staff were required to watch each lift demonstration video before they could progress to the next portion of the module. We thought that since this was mandatory education, we had all the different members of the healthcare team completing this. We wanted them to review the education videos on how to use each of the pieces of equipment that we had. And then we went into the bedside mobility assessment tool. And really, we thought it was important that staff understand why we were implementing the BMAT and how it would help them and our patients. So there were several slides to highlight the importance of having a mobility tool and then why we were creating a focus on mobility and safety. We had our nurses start incorporating the BMAT level into their shift-to-shift handoff communication. And we also worked with the healthcare team, including physicians, to create a protocol on when it might not be appropriate to mobilize a patient. So if the patient didn't meet their mobility goal, staff or weren't up and moving, that staff were prepared to communicate why the patient wasn't up and moving. The final component of our education was really the competency-based orientation and the hands-on demonstration of our safe patient handling equipment at a unit level. What we found was there was variation unit to unit in the hands-on demonstration of our equipment. So as a result, our mobility and safety committee decided we needed to work with our nurse professional development specialist, which I think some organizations may refer to these as nurse clinical educators, and have that team shift the education to that team for our safe patient handling training as part of the onboarding process and for annual training to assure all employees coming into the inpatient setting have the same training and expectation on safe patient handling equipment alignment with the BMAT levels. Okay, so I think this We Move Together campaign really was an important part of creating a movement amongst our team that this was something we were going to have to do together. So I think this is the fun part of my presentation and the work that I've been able to do. So in February of this year, we launched the We Move Together campaign, and that was to raise awareness around the immobility epidemic at hospitals across the United States and here at Nebraska Medicine. So promoting mobility and reducing falls really requires a comprehensive approach using proactive measures like the BMAT to encourage movement and targeted interventions. And no one discipline can do this alone. Thus, I came up with the idea of We Move Together. So it's not just nurses getting patients up. It's not just PT and OT. We involve our physicians. We rely on our respiratory therapists. We rely on the patients and their families to be engaged in this process. And I truly believe our staff want to get patients up and moving, but they don't always know the best approach to doing that. So really, that's why the BMAT tool was so important in the first step of the We Move Together campaign, because it guides our nurses to meet patients where they're at with their mobility and directs them to use our safe patient handling equipment to mobilize their patients. While the focus on the We Move Together campaign is to promote patient mobility, it's equally important that we're committed to keeping our patients and our employees safe, and we highlight that in this campaign. So I want to be able to show this video, but I know I'm going to be running short on time. So at the end of the presentation, if I'm able to come back and share this video, I will. Otherwise, the link will be in here, and then you can go view this video after the presentation. But this is a video that we kicked off our We Move Together campaign. It had ICU nurses, we had an acute care director, a critical care director, myself, a physician, really talking about why it's so important that we work together to get our patients up and moving. And so we kicked that off after we rolled out the BMAT. The next thing we did after the BMAT and after the We Move Together campaign, we engaged our marketing team to keep the momentum of the campaign going and ran an article on the rollout of the BMAT and the impact that has for our patients and employees, really demonstrating how we're making strides in patient mobility. The next thing we did, and this actually, I just got the email with the video highlighting this patient last night, but I wasn't able to use it today. But really highlighting your patient's success and how incorporating safe patient handling equipment can help progress your patients keep them safe, and also keep your employees safe. And so this particular patient, she started on our neuroscience ICU, and she had a stroke. She was flaccid on the left side. She started out as a BMAT2 patient. We utilized the Sarah Plus. We were piloting this piece of equipment on that ICU and deciding whether or not we wanted to purchase it. So she started out using this Sarah Plus and being able to do the sit stand function of it. And when she went down to our neuro science med surge unit, we were able to progress her to the walking component of that. And I just want to show this video. I know we viewed it a little bit before the presentation, and the sound is not real great, but I'll just talk through what I want to highlight here is you see the patient, the PT and OT are supporting this patient. At the front of the Sarah Plus is one of our rehab supervisors who's supporting the team and utilizing the new patient equipment. In the upper right-hand corner, you're going to see a physician standing there watching what's going on. And the person videoing this is the patient's mom so we have the family engaged in this. And I think this just really is a great demonstration of how you can create a We Move Together movement. So let me see if I can get this started. There you go. And I do have permission from Vicki to use this video. She was very excited about this piece of equipment and how it helped her progress during her hospital stay.
That one was good.
You can see Dr. Phillips over there in the right-hand corner.
Look at Laura's beautiful face across from me. There you go.
There's Dr. Phillips. And then I'm not sure if you can hear it.
To Tiffany Marco, Dr. Phillips, and say thank you very much for allowing us to purchase this piece of equipment. I will.
So Laura, the rehab supervisor, is encouraging Dr. Phillips to email our acute care director and let her know how much we're utilizing this piece of equipment and we need more of them.
I have videos from start to finish.
And that was her family member saying, I have videos from start to finish. And so I'll stop it there, but I think never underestimate the value of getting the employees and the families engaged in part of this process. And I actually did not realize how much a piece of equipment could really engage our patients and families. And that has just been an exciting moment for us here at Nebraska Medicine. Okay, so piecing it together. Strong evidence suggests that traditional approaches to patient handling, specifically manual lifting and training in body mechanics, is not effective in eliminating caregiver injuries during patient handling and mobility. Research has also shown that having a safe patient handling program can reduce the number and severity of injuries to healthcare workers and translates to savings in workers' compensation. Several studies have also shown a significant difference in caregiver perceived exertion and patient comfort when using safe patient handling equipment to move and transfer patients. So in Jake's presentation, his takeaways from this as how can this research be applied was gait belts alone were more demanding than when we used a gait belt and slide board. But even slide board transfers with a gait belt exceeded the suggested ergonomic limit for compression force. So ultimately, the safest means of performing transfers is generally with a mechanical lift. He also pointed out that healthcare workers are used to doing very demanding tasks and have high standards for what is demanding. And I absolutely believe that to be true. And I really hope that we can change that mindset with our We Move Together campaign. So then in part 2, we heard Neil share some data on and highlighting how the assistive air devices or lateral air transfer devices in ceiling lifts may provide adequate risk mitigation for heavier patients, but manual repositioning with the draw sheet, manual repositioning aids alone, and even with Max Inflate and Trendelenburg, that those alone really aren't an acceptable standard for moving our patients. On our main campus, we have 4 different patient towers, each of varying ages, each tower with different room setups and with different safe patient handling equipment. So a few of our units have ceiling lifts, but most of them do not. So having a standardized approach may apply to having a policy and a procedure and a mobility assessment tool. But if each of your nursing units is different and there is a variation in safe patient handling equipment and mobility assistive devices, how do you implement best practice? Can you incorporate what we learned from Neil and Jake in addressing safe patient handling if you're limited or maybe even don't have that safe patient handling equipment? Can you optimize maybe your room setup and interventions for safe patient handling to minimize the risk of injury to both the patient and the healthcare provider? I'm going to talk a little bit about how we address some of those questions. And one thing I had to continue to step back and tell myself is, and ask myself if I was letting perfection get in the way of progress, because we absolutely don't have the ideal room setup and state in all of our towers. We have a couple units that are close to that, but the majority of our units are not. So do we not do anything because we don't have the ideal state, or do we utilize what we have and implement the next best practice? So we worked, what I did is work with our executive sponsor and some physician champions. We did a house-wide inventory of all of our equipment we currently have and a needs assessment of what we were lacking to establish a culture of early mobility and employee safety. I was fortunate enough to be able to secure some emergency funding of over $250,000 to support our equipment and mobility assistive devices needs. So as an occupational therapist, task analysis is really a fundamental part of our practice. And I draw upon that in creating and addressing mobility and safe patient handling equipment needs in our various inpatient nursing units. So instead of standardizing our approach to safe patient handling and mobility throughout the organization, I broke it down and looked at each individual unit, and we're continuing to do this because we are not where we need to be and we still have a journey ahead of us. But these are some things that we did to really get us moving in the right direction. So identifying your patient populations, really understanding the specific needs of the different patient groups is important. Their unique characteristics, the challenges of the various populations with lines, drains, tubes, precautions, and weight-bearing status. And what you'll find is the safe patient handling equipment you need in an ICU may be very different than the safe patient handling equipment you need in a general med-surg unit. After that, evaluating different care delivery models is another approach to implementing mobility and safe patient handling practices. Can you utilize a different model of care to support integration of early and progressive mobility and safe patient handling practices that support patient safety and staff efficiency. At Nebraska Medicine, we've implemented several different models of care to address our nursing shortages and to promote early and progressive mobility, including mobility aids on some of our med-surg units, care pairs, which is a nurse and a CNA paired together, sitter getters, transport aids. We've increased PT and OT staffing on certain med-surg units. We're currently piloting PTAs in our ICUs to address activity at all the BMAT levels. What I will say, though, that one model may not meet every nursing unit needs, and that's really where looking at the individual unit is beneficial and can be more effective than trying a standardized approach to creating your safe patient handling program. So I am going to go ahead and I have some examples of just how I utilize those items to determine what we needed on our different nursing units. And so this is an example of our cardiovascular intensive care unit. We identified our major patient population, our care delivery model, which I think is probably similar to most other ICUs and pretty standard throughout all of our ICUs unless a patient is on ECMO. Asked employees what their barriers are to getting patients up and moving on this particular unit. Really nurse availability with the devices that require a nurse to be present to get the patient up is one of the top barriers that they identified. And then just having sternal and surgical incisions and precautions. And this is our most complex ICU, but they really are one of our leading units in getting patients up and moving. And that is because the staff is so focused on it, but it is also expected by the physician. So having physician engagement in this process is really important. So looking at their current equipment, this is our only ICU that has ceiling lifts. They use turn and position systems. We have our specialty beds, and we have mechanical and non-mechanical sit stands. I gave the example of the employee who had a back strain, and that was on this unit where they have ceiling lifts. So on this particular unit, one of the things we want to focus on is we have lift sheets on the units, but we're not using them. That would be best practice. We heard that in Neil's presentation, that is best practice. You have the ceiling lifts, you have the lift sheets, we need to use them. The other thing on this unit is they've had some assisted falls when getting patients up for daily weights or just when ambulating patients and trying to progress their endurance. And so we, as part of a pilot program, we piloted the Sarah Plus, and we purchased a Sarah Plus for this unit with a scale, with the idea that having that sit stand component for doing the daily weights and the ability to do having walking pants and walking in the halls might reduce our assisted falls. So that's what we're focusing on for this unit. This is one of the measurements that the metrics that we pull. And again, there's that BMAT Go Live, and I'll just point that out so you can look at the metrics before and after. But we are collecting this data on, say, patient handling equipment usage. I can drill down and see if the staff are using ceiling lifts, portable lifts, or a Hoyer lift. When they're getting patients up and moving. I can also look at it by discipline. The gray is nursing, the teal is PT/OT, and see who is utilizing the equipment. You can see, since we pushed out the BMAT, we have some more consistent use of our safe patient handling equipment. And what you'll notice too is the teal, the PT and OTs are utilizing it more as part of their therapeutic intervention and treatment sessions. And that's specifically related to the Sarah Plus. Now look at our surgical intensive care unit in the same tower, but they do not have ceiling lifts. And so they have complex patient population, very challenging patients, high acuity, very variety of BMAT levels. We have our liver transplant patients on this unit. And their care delivery model is similar to our cardiovascular ICU. They have less beds, but they have no ceiling lifts. And so I know when I look at their equipment needs and opportunities that overhead ceiling lifts are not going to happen. We are in the process of funding a new patient tower that's going to have 500 beds. And I know leadership is not going to put funding into an older building that will be obsolete. So we don't want to do nothing. So what's the next thing we could do to minimize the physical efforts that our staff have to do when boosting, repositioning, and transferring our patients? And so for this particular unit, what we are looking at is education on bed functions and incorporating friction reducing sheets into our standard practice. I think bed functions are probably the single most underutilized feature by our healthcare teams in combination with mobility assistive devices and encouraging the patient to reduce the workload for the caregiver. So we're really going to be doing some education and focusing our efforts on trying to optimize the use of our bed functions in combination with mobility assistive devices, since I know we can't install ceiling lifts. The barriers the staff gave me to utilizing portable lifts is the rooms are very small, and they're not wrong for them to use the portable lifts with a lift sheet. And so what else can I provide them that I know that will be easy for them to get and they might incorporate into their standard practice? So that's something that we're focusing on for this group. The other thing is we're looking at a different care delivery model, incorporating PTAs into the unit and having them do different activities based off the patient's BMAT level, really focusing on our BMAT 1 and 2 patients that currently I feel like don't get the interventions that they need to help progress their mobility. Now we're gonna, and then this is, I like this slide because this is their safe patient handling equipment usage. So you can see where the BMAT go live, where they were at prior to BMAT go live. Then you can see where we implemented the Sarah Plus pilot. So we were able to utilize a Sarah Plus for just under 90 days to see if our staff would utilize it, and then decided to purchase it. And then it shows you when we purchased it, how much not just our nurses, but our physical and occupational therapists are incorporating it into their treatment sessions, which help keep them safe as well as progress the patients. Then here's one of our general med surg units. And so this is one of our towers, no ceiling lifts. It's 80 beds of med surg. They do not have mobility aids where some of our other med surg units do. And they have mostly portable lifts. And so over there, we purchased Sarah Plus for our ICU. So right now, the Sarah Plus is not available to them for sit-stand transfers and walking patients. And I know right now they're not going to approve mobility aids. So what can we focus on right now for them to increase our employees' safety? And that's really use of the friction reducing sheets and optimizing our bed functions. Now, here is their safe patient handling equipment usage. And you could see that their usage has gradually gone up since the BMAT go live. And then I want to talk about our neuro specialty med surg unit, because this, again, like our CVICU, who has ceiling lifts and really has the most ideal state for safe patient handling and mobility, so does our neuro specialty med surg unit. They have ceiling lifts, but not only do they have ceiling lifts, they also have mobility aids. And they have been fortunate. They're very familiar with the BMAT because we implemented the BMAT back on our neuro unit almost 4 years ago, and the mobility aids 3 years ago. They have ceiling lifts. They have access to our Sarah Plus because we have it on our NSICU. And there are opportunities, even though we do great work on that unit, there's still opportunities for improvement, and they do not utilize their lift sheets with their ceiling lifts. So that's one thing we'll be focusing on for them versus having them use their taps for repositioning and boosting is the lift sheets for ceiling lifts. And then check out their safe patient handling usage. And you can really see how you combine mobility aids, a different care delivery model, with providing the right safe patient handling equipment and support really does for increasing our safe patient handling usage and creating a focus on mobility and safety. All right, so measuring success. I think I can get through this and still have a few minutes for some questions. So I worked with our analyst and one of our certified nurse specialists, and we created this mobility dashboard. And this really gives us a sense for how we're doing getting our patients up and moving. And this is a snapshot of the overall hospital. And it shows you where the BMAT Go Live was and the Hester Davis. And our goal is to get our patients up and have 3 activity episodes per day. And that shows you where we're at with that. And then we collect how far ambulation total distance and how much our patients are getting up and moving. So that blue line there across the ambulation totals is when we implemented the BMAT. And you'll see the data that has changed since we implemented the BMAT and the Hester Davis, and then added additional mobility aids to 3 more med-surg units in June of 2024. We also can look at the top, you see the BMAT level distribution, and I do utilize that information to because I can drill down to the individual unit level, so I can see kind of what their percentage of BMAT 1, 2, 3, and 4 patients are, and then we can tailor to our safe patient handling equipment and our mobility assistive devices based on the percentage of BMAT, patient levels that they have. So the next thing we look at, and I already showed you this, is our safe patient handling equipment usage. And so this is the whole hospital. And you'll see that is on the furthest one in July up to 640 usage. I expect that to go up, and hopefully we start seeing our worker injuries go down. You can also look at, we collect total falls and total falls with injury. And, the myth that you get patients up and moving and they're going to fall. And I think there was such a focus on that we've created an immobility epidemic. But this just shows you, we implemented the BMAT, we aligned it with safe patient handling. We implemented a new falls tool. We're getting more patients up and moving, and our falls are not going up. They may be starting to trend down. Then we also collect hospital length of stay, and you can see our length of stay is starting to trend down. Mobility is medicine. Getting patients up and moving is one of the things that makes them be able to discharge and go home. So we also collect hospital discharge disposition. That blue line up there is all those patients that go home. And then, of course, we still have patients that go to skilled nursing facilities and acute rehab. So my final thoughts really to help reduce injury and improve safety outcomes. And, I was really focused on the hospital setting and acute care, but I think there's portions of this you can really translate to post-acute care and even home health and potentially into your ambulatory clinics. But implement a mobility assessment tool that you can align with safe patient handling, create a policy to set the expectations for use of safe patient handling equipment and mobility assistive devices, so you're minimizing manual patient handling. Incorporate employee safety as part of your safe patient handling and mobility program. Advocate for a safe patient handling coordinator or injury prevention specialist. I didn't talk about that today, but I'm still working on it because I really wear 2 hats in this organization. And I feel like employee and patient safety could be a full part-time job and deserves a full-time efforts. Engage all levels of leadership by referencing the positive outcomes from having a mobility and safety program. Really utilize your metrics to drive your program. Raise awareness and generate excitement by engaging your marketing teams. Find champions, start small, expand, and don't let perfection get in the way of progress.